Hello, everybody. First of all, thanks to my friend Shungling for inviting me in this conference. I'm very glad to speak to you about such an important subject: health insurance, universal coverage, challenges, measurement, evaluation of strategies. Those are important issues that really impact the life of people across the world and day to day. There are many studies that have done, not so many. There are some studies that have done and published in peer-reviewed journal, and the world are starting dialogues about health insurance and universal coverage in the US, in Africa. And I'm just coming from a conference in my region, East African region, comprising by Kenya, Tanzania, Uganda, Burundi, and Rwanda, where we are talking about harmonizing access to care through universal coverage using health insurance. So I'm very happy to share with you my experience, the experience of my country. I want to portray for you first the health sector. The health sector is comprised by, at community level, at village level, and a village is 100 to 200 houses, and each village have 3 community health workers. 2, we call them binôme, a man and a woman, who are there for common diseases, diagnostic and treatment of malaria, pneumonia, diarrhea, and we are just going to start to teach them about non-communicable disease, the new chapter we are starting in our health strategies. But after the 45,000 community health workers, I forgot to tell you, the third community health workers is what we call is in charge of maternal health, meaning women that have just delivered and the child for the first year. On top of those 45,000 community health workers, we have health centers. In each sector, we have a health center, 450 health centers. Managing those health centers, we have district hospital. We have 42 district hospitals. And on top of that, we have 5 referral hospitals and 1 regional hospital. So this is our health system. The health insurance we have at community level allow you to go through all the system according to needs. But you have to be referred from community to health center, from the health center to the district hospital, from the district hospital to the referral hospital, from the referral hospital to the regional hospital. And at each level, you have more specialized care. At community level, those are lay people. They are not health professionals. They are people elected by their pair at village level, and once they are elected, we are training them to give really basic care. But those basic care are 80% of the burden of disease in our country. This solves 2 problems, distance and infrastructure. You know, when you are sick, and you and me, you are certainly like that, we just say, we'll see tomorrow for consultation. And sometimes tomorrow is too late. Now that you have the capacity to have care in your village, you are consulted the same hour of when you feel the problem. You got diagnosis and treatment. And 24 hours later, if there is no improvement, the community health worker sends you to the health facility. Normally, you will not go before that. And sometimes, one day after, you just say, okay, I will see tomorrow if I can be better. But now, the community health worker is trained and committed to bring you to the health center 24 hours after if there is no improvement. As you trust the community health workers because you have elected that community health workers, you are obliged morally to go and consult. The result is more care, more quickly. In the health center, at that level, you just have nurses. And the nurses normally treat almost everything. But when they cannot manage, they send you to the district hospital. There you find doctors and most of the time, sometimes, a specialist. When they cannot manage, they send you to the referral hospital where there is equipment, scanner, specialist, etc. And for some diseases, some treatment, they send you to the regional hospital, King Faisal Hospital. All this with the same health insurance. The only thing requested is a proper referral. That means you don't overuse and you are well transferred. So, after portraying our health insurance, I just want to present you what are the laws governing our health system. Our laws are done bottom up. From up, they come down to the bottom and come again up. And after this wide consultation, those laws pass through the PS Forum, Permanent Secretary. When the PSs agree across sectors, before it was across communities, when across sectors PS, Permanent Secretary agree, it passed in the SIC, what is a ministerial forum for last agreement. And when the ministers agree, it's not in the cabinet. They just discuss technically, everything is possible, is there money, can we do that? Then it goes to cabinet. Meaning, when the law is in cabinet, we all agree, we all know, everybody is aware. We have disseminated before agreement. And there we just go for say, we all agree. Or we all agree on this, but we disagree on that. And we take final decision. And by this involvement of the communities to the top leaders, passing through the local leaders, passing across sectors, the laws are really what reflect the needs of the population. It takes time, but in reality, it's winning time. Because when we all agree, implementation is so quick and reflect the needs of each and every one. This system needs a true decentralization. And decentralization is very different than delocalization. Decentralization means the district have a true power. It's not a delocalization of the power of the central level. And the districts are in charge of the district hospital. I remember you the level, community health workers at village level, health centers at sector level, district hospital at district level, and after that referral and regional hospital. At district level, the Ministry of Health is in charge of assuring that the policies are followed, the norms are followed, the quality of care is there, and the access to care is assured. But the mayor is the one who has to respond about all of this for his or her population. The centralization level is really, the different levels of decentralization are really important for the success of the health sector. Now, where does the health insurance come? It is at sector level. I remember you, the community health workers at village level, health centers at sector level. At sector level, people give their premium. The health insurance is owned by the community, meaning in all the sectors, they have They collect their premium, they put it in a bank account, it belongs to them. They send 10% to the Ministry of Health to assure the hospitalization at referral and regional level. And they've sent 45% at district level to assure the payment at district hospital when hospitalization is needed. And they keep 45% for the care they give at sector level. Now, what happened at district level? When in the same district you are visiting friends and you are sick in another sector, the district pays the bill. This is the roaming at district level. Now, if you are sick in another district, the portion the Ministry of Health has received, 10% of all the premium, will pay the bill for any Rwandan that is sick out of his district or have to be hospitalized in the referral or regional hospital. So this is the way it functions. I want to tell you that more than 90% enrollment has been seen last year for the Mutuelles de Santé, the community health insurance, and the rest of the Rwandan are assured by private or people like me as civil servants. And we had 98% of Rwandan that have the benefit of a health insurance, and they are all working in the same way. So, with this, we have assured financial access. With another process, the performance-based financing, we assure quality of care delivered. And meaning, for each care you receive, based on quantity, we award the health facility or even the community health workers with a certain amount by type of care provided. There is a record. We have assured this number of this type of services, and they receive an amount of money accordingly, and if they prove that the quality of care was assured. So we have financial access, and we have quality of the services, because I want to recall that quality without access is not recommended, as well as access without quality. This system allows both. Now that we have assured access, we need to assure the people that will provide the services. And we have a shortage of personnel, a shortage of professionals, a shortage of nurses, a shortage of doctors, and a shortage of specialized nurses and specialized doctors. To solve that problem, we have just started a program called Human Resource for Health. We have the policy on human resource for health. We have the strategy for human resource for health, and a portion of that strategy has been transformed on an action plan called Human Resource for Health program. And for 7 years, through that program, we have contracted 13 American universities, and among the best. If you want to know more about that, I advise you to go to the website Human Resource for Health, either the Ministry of Health website, either the website of that program. You can Google it, you'll find it. But this program will bring around 100 teachers a year from your universities, 100 faculty members that are going to mentor Rwandan teachers to be better teachers, are going to mentor residents to be good specialists, and students to be good doctors, nurses to be good nurses, etc. Even specialized nurses will benefit. We hope that over 7 years, having this number of faculty members from the US, our system will be strong. We'll have a strong faculty of medicine, and we will have a strong number of teachers, faculty members, Rwandan one, and the residents and doctors. So we will have created the capacity to provide the services. So on top of creating the system, we'll have created the capacity to deliver. There is another component. It's not only the supply side. We need to work on the demand side. And the demand side is to teach the people, first of all, health is a right. Health is your right. Seek it and make it happen. So by creating the health insurance and creating access, creating quality in access, and creating the numbers of people that can provide you care, we have made the Rwandan use of getting health care, quality care, and they are going to be more and more demanding of care, because I want to recall that there is an addiction to good care. Don't be surprised. This is a good thing. The more you get quality care, the more you have quality care, etc. Don't abuse. If you do, you kill the system. But if you just take what is required, it's just using your right to health. With the health insurance, we have increased uptake of primary care. We have increased uptake of secondary care. We have increased life expectancy. And we can measure that. There is a study we did with Changling. I think she will present that to you during that conference. We can see that for diarrhea, for maternal health, for pulmonary disease, it's so evident that it's almost breathtaking. And it is so evident that the dialogue now across country and across the world, I hope that those type of evidence will make people fight for access to care and access to universal coverage for health insurance and universal access to care, something that will be so common that one day people will ask themselves, how was it before? This should have existed from the beginning of the humanity. So with that, our life expectancy have increased from 28 in 1994 to more than 55 in 2010. We have reduced maternal mortality by 50%, under 5 mortality by 50%, under 5 mortality by 50%, and we can see that across services there is an equity between men and women, there is a gender equity, there is an age equity, and it's not that we have finished. We are there for primary care. And our life expectancy at 50 years, we are very proud of it, because we come from something 28, but it's still too low. We want one day, and soon as the best, to have the same life expectancy as you. And my people deserve it, and we are working hard for that. And the value that are driving us are science, because we want to do everything evidence-based. Participation, I explained to you how it comes from bottom to the top when we identify a problem. And we're bringing back to the bottom to see if the solution proposed is okay. And then we pass the law. It's equity based on gender, on age, and on geographic coverage. We would like all Rwandans not to work more than 1 hour before getting access to care. And we are focused. We decide to solve that problem that we have identified, and we go for that. And as we have learned to work together, we go together and we solve the problem. So the other one is national ownership. And this is also one of our focus. And the way we do that with our partners, and for that we mobilize them. Mutuelles de Santé, our community health insurance, have strengthened the health system. I guess that it's somehow obvious because as people have access to care, they pay. It's not that they don't pay. The money entering in the system allows the system to buy more equipment and to pay more staff and give more service to the people who pay more, etc. So it's a wheel that is for our development and is going fast. The mutuelle are at section level. It's owned by the community. And this is the identity card of that mutuelle. We are not ready to change it. We don't have to have police to assure that people are enrolled, even if there is a law for that. Enrollment is mandatory. But the community mobilizes their members to pay. And they do that in a gentle manner. There is no pressure. Everybody will contribute because it's the neighbor who just make the neighbor contribute. And they have experienced it, and they don't want to lose the mutuelle. So the mutuelle is really owned by the community. Those research we have done has evaluated what mutuelle is and what mutuelle has allowed us to achieve. The study we have made with Shanling is one of them, a great one. I'm very proud to have made that with her, and we have enjoyed time making that with her. And in that study, we have looked at the relationship between increasing access to care with the increasing of coverage and decrease of catastrophic expenditure. All this is, she will tell you, she will show you the graphic and everything. Now we are thinking, how it comes so late? We should have done that 20 years ago. I say 20 years ago because before I was not there, but we should have done that long time ago. But I want you also to reflect beyond the study we have done, beyond Rwanda, because there are great experience outside there. Thailand, China, Cuba. The best experience for me are the ones who are national, not in a pocket of the country, what we do in Rwanda. When something is good for one citizen, should be given to all. This also is the principle of the word universal. So, I can tell you that it has increased uptake of basic care from 13% to 33%. This is also something that will talk to you, I'm sure. Skilled birth attendance delivery in health facilities with people that are trained for that has doubled. This explains the decrease rate of death. And the study will show you also that the poorest are the ones who benefit the more. In many countries, it's the rich quintile that benefit the more. I'm very proud in my country that the more vulnerable that are benefiting the more. And this is, for me, the core, the essence of what human right is. When a vulnerable person benefits more than somebody that is not vulnerable, that means you break the barrier, the handicap to welfare. I'm very proud of that. The cost of health insurance have shifted over time, and it has shifted to learn the people at community level what a health insurance is. We start in 1999 by 1,000 per family. because it was a new concept. How can you pay without being sick in case you are sick a day? One day, one coming day. So this was not in our culture. With this $1,002 a year, we have bring all the family to care. They love it. So when we say it will be $2 per capita in your family, they took it. And after a couple of years, when they find it so good, we say now you are going to pay according to your revenue, because the system is a system based on solidarity. It is not normal that somebody like my mom, I love my mom, but she pay only $2. And the person who work for me at home pay also $2. It's not fair. So my mom will pay now $12 a year. And the person who work for me at home will pay $7 a year. And the people who have nothing, who are the poorest, the 25% of the poorest in Rwanda, will pay nothing. So this is also what we call equity. But this equity, we build it with time and we build it with consensus. Now, Mutuelles de Santé is mandatory. Before it was not. We make people love it. We have created demand. And when we had more than 90% of adherence to the Mutuelles de Santé, then we pass a law that it's mandatory. Because we will not run after the people who will not pay. It's going by itself because the community have owned it, the local leaders have owned it, and it's an issue for each and every one. The lesson learned out of that, I have learned that best practice have to be studied. You have to extract from that some principle. Never try to replicate what others have done. Just use the principle that has moved them. And the principle, I want to recall them, it's science, evidence-based, participatory process. Everybody have to be on board and agree. Be focused with ownership and always left nobody out of benefit, especially the most vulnerable. Of course, everything based on equity. I think I have shared with you everything. Once again, Shanling, thank you, big hug and big bisou. And let's go for the next frontier. What are we going to study next? Bye.